Welcome, everyone. My name is Mike Cantor. I'm the Chief Medical Advisor at Aeroflow Health, and it's my pleasure to welcome you to today's webinar, Food is Medicine, Empowering Health Plans to Integrate Nutrition for Member Wellness. We've assembled an outstanding group of panelists and a really great set of topics to go through as it relates to food as medicine and the role of health plans. We're helping to celebrate National Nutrition Month, which is March, and really looking forward to a fantastic discussion. So let me jump right in. Just a few things before we get started. Really, the goal of this series of webinars, and we do have one roughly on a monthly basis, sponsored by Aeroflow Health, is to be able to bring to you interesting perspectives and ideas on how health plans can improve the care of their members, whether that has to do with how to engage them during open enrollment and right after, or as we discussed in our last webinar, how to work together with your durable medical equipment and other companies to really share data, to be able to improve the health of your members by ensuring that they're getting the most comprehensive care possible. If you do have questions today, and we hope you do, if you're watching live with us, please submit them through the chat. We will be monitoring that. Happy to have your questions. We have time for that at the end of the webinar. So really looking forward to what we hope will be an interactive portion of our session today. So let's jump in. I'm going to ask each of the panelists to briefly introduce themselves. As I mentioned, I'm the Chief Medical Advisor for Aeroflow Health. My background is in geriatrics, and I'm also a lawyer, and I have a lot of experience working as Chief Medical Officer for health plans, healthcare provider organizations, and organizations like Aeroflow that support the work of health plans with their members. Ryan Bullock is joining us today from Aeroflow. Ryan, do you want to say a few words about yourself?
Sure. Ryan Bullock, Chief Strategy Officer with Aeroflow Health. We are a national provider of durable medical equipment products and services.
Great, glad to have you with us. Sophie Lauber.
Sure. Hi, I'm Sophie Lauber. I'm a registered dietitian and board certified health and wellness coach with Aeroflow Health. I have a background in communication and clinical dietetics, and my passion is really with plant-based nutrition and the prevention and treatment of chronic disease. Over the past few years, I've honed in on the coaching aspect of nutrition to really empowering patients to take control of their health and increasing their confidence in their ability to change, and fostering a love for food and healthy living. So I'm excited to kind of bring that patient perspective to our discussion today.
Great to have you with us today. Holly?
Good afternoon. Holly Freistadt. I'm the Senior Director for Feeding Change at the Milken Institute. The Milken Institute sits at the intersection of finance and health. And I like to say that Feeding Change sits at the intersection of finance and food systems. And I have a background of food systems and bringing that to the Institute, and I lead the Food as Medicine Task Force.
Great. Welcome to our webinar. So let's jump in. Lots of things to talk about. Food as medicine is a very, very hot topic these days because of the very close linkage between health and nutrition. They used to say you are what you eat, and I think that's still the case in many ways. And luckily, we have with us experts to help us understand what do we mean when we say food is medicine? And what does that mean for health plans? What is a food prescription? And how is that different from a food as medicine program? Is food as medicine a benefit design? Is it something that they pay for food? Is it how you think about food? Holly, help us understand what this is and what it means for us and for our industry.
Great. Thank you, Mike. It's a really good question. And to be honest, if you ask that question to many different people in the field, we're all going to have slightly different answers. And the reason is there's no standardized definition of food as medicine. So what we're seeing in the field right now, and especially with the White House commitment, is food as medicine is really turning into a movement, right? Acknowledging and understanding the value of nutrition as part of healthcare and as part of treatment and prevention. And this acknowledgement that we can't see health outcomes the way that we need to see them if we don't understand and acknowledge nutrition and the role of food. So when you think about the role of food as medicine, I use the terminology, and once again, it's personal, food as medicine prescriptions. Really acknowledging and noticing that it needs to be about treatment plans. So a person has a chronic condition, right? And usually food insecure, and then we look at how do we treat that patient. And when we see it I see it as a continuum of services. It could be from produce prescriptions, which is really a prescribed prescription for produce for a medical condition. It could be medically tailored groceries, or it could be medically tailored meals. And when we think about benefit design, I mean, in my worldview, it's not just about a program. It's about how do we meet the patient where they are. And so it may be that they need medically tailored meals because they just came out of the hospital, and then maybe in time they need produce prescriptions, and then they're fine and they can be off the system. But that it needs to be a part of their treatment plan.
So is it only for people who have food insecurity, like they can't get access to food, or is this for people who are trying to eat healthier because they have a chronic illness or because they just feel like they want to lose a few pounds? I mean, Americans think about food in a very complicated and somewhat highly divergent ways. Just what I'm still not exactly clear what you're
So
getting.
it all depends on when we think about a covered benefit, right? And so we're thinking about whether it's health plans or you're looking at Medicaid 1115 waivers. If it's a covered benefit, right now we're looking at who needs it most to see the outcomes, health outcomes be improved. So a lot of this conversation is who is most vulnerable, and the most vulnerable are those who are food insecure with health conditions. And so I think a lot of this effort right now is focusing there, but absolutely food as medicine is and needs to be a part of all individuals and all health conditions, but whether it should be a covered benefit or not, I think that is still to be discussed and more further information.
Got it. So Sophie, maybe you can help us understand a bit more about how do health plans think about nutrition as part of a broader treatment strategy? So leaving aside the issue of whether they should pay for people to have food and who should be covered and all of that, what what is the traditional approach to health plans towards nutrition and food as medicine, and how is that evolving and changing?
Yeah, I mean, I think traditionally there hasn't really been an approach. And now that food as medicine is becoming, more relevant or more part of the conversation, I think in a literal sense, we're seeing food and nutrition as critical interventions for disease prevention and for treatment. And like Holly was saying, it means supporting members who need extra support to meet their nutritional needs, so they can manage their disease states effectively and have the inputs they need to be successful and food secure. And I think referring to the food as medicine program as we're all, slowly defining it to be, it's a recognition of the broader social determinants of health that go into patients developing disease and addressing these root causes rather than waiting for patients to enter the healthcare system or continue to inundate it. So figuring out, how to prevent patients from utilizing, large portions of the healthcare system and providing them what they need in order to live a healthy, fulfilled life.
Yeah, so I learned as a geriatrician and as a general internal medicine doctor, health is more than the absence of disease. It really is about keeping people healthy, helping people who may have been ill recover and get healthier if food is related, nutrition is related, in many cases it is, to the reason that they were ill in the first place. So Ryan, help me
Yeah.
understand. Food is medicine, we've heard as a movement. We heard nutrition as a core part of health. What's a nice durable medical equipment like Aeroflow Health doing in a place like this? Why are you guys interested in food as medicine?
Yeah, thanks for that, Mike. I guess it goes back for Aeroflow Health. It really began with our mom and baby division. In that division, we were supplying breastfeeding products and recognized the need for also providing lactation counseling to help support the holistic approach to breastfeeding, along with the products that we were currently supplying. And then naturally in that conversation, nutrition began to come up in those sessions, and we began looking at bringing on nutrition therapy within that division. And it really opened our eyes internally to look and see what are the other product categories and disease states that we focus on supplying patients with their durable medical equipment products that have a correlation to food. And Aeroflow diabetes for us was one that just naturally rose to the top and led us to Sophie.
Great. Excellent that you guys are engaged, because I think clearly, just like nutrition, durable medical equipment plays a very important role, especially in care of patients, people with diabetes. So we've heard that the food is medicine is a movement. It's certainly gaining traction. There's a lot of attention, a lot of focus on it, partly because of its relationship, as you said, Sophie's social determinants of health. The recognition that health really is more than just the medication. It's more than diagnose and treat, right? It's way broader than that. So, Holly, maybe I'll go back to you. What are some successes that the movement has had recently? And what are the challenges that are currently being faced? Where are the opportunities based on what's been happening in terms of level of research and attention and additional funding, but also significant barriers still remain? I'm sorry, Holly, you're on mute.
Sorry, I'm not a rookie. I shouldn't have made that mistake. So first and foremost, before I came to the Milken Institute, I was the chief of food policy and planning at the city of Baltimore, and I led the nutrition security response for COVID-19. And one of the key lessons that we're seeing right now in this food as medicine movement is understanding how important food insecurity plays in impacting health conditions, and that access alone is not enough. And so when you jump forward to where we are now, the White House commitment, I think, is one, in the White House Conference on Hunger, Nutrition, and Health, I think has been one of the greatest successes in mobilizing stakeholders and unifying all of us to point in the same direction. And when you look at the successes of the last several years of food as medicine, I would say we're finally seeing these pockets of pilots coming to scale. We are seeing evidence building way beyond 100 to 200 population groups, 2000s, in many states. So evidence is building, seeing it at scale. We have seen movement when you look at Medicaid 1115 waivers. We went from, a couple of years ago, from a handful of states to close to between 7 and 12, depending on how you count in their status, whether they're approved right now or pending. And so I think that we're pointing in the right direction. I think that there's some of the challenges we're seeing. There's several. One of the challenges is we need to be ready with implementation as these policies and reimbursements scale. So we need to be looking at the data technology, interoperability. We need to look at the financing, where are going to be the gaps in financing, even if reimbursement happens, that will cover the cost of food, but there's so much more than just the food. And so a lot of the work that we're doing at the Milken Institute is looking at the future. What needs to happen as these policies pass? How do we make sure we're ready when it happens?
One of the big questions is sort of why should health plans pay for this when we have SNAP, we have other nutrition programs, and at scale, you're going to bump into the reality that the same people who may be getting some of those other benefits might also be eligible for health-related based benefits. What's the thinking about how to allocate sort of the responsibility as well as the financial responsibility for food as medicine?
This is one of my favorite questions to answer. So let's be clear. When we talk about SNAP, Supplemental Nutrition Assistance Program, right, we're talking about supplemental the amount of food so you're not hungry. It's about hunger, right? So you don't skip meals, that you're able to feed your family. It's not necessarily about health outcomes and treating disease, right? And so I think that when you're looking at layering, and I see this really as a stacking of benefits, all right? So it's not food as medicine should never replace federal nutrition assistance program. That is not the goal or purpose, all right? So if you have someone who is already on SNAP, right? We know that that's supplemental. That's in the definition, supplemental benefits. That is not necessarily enough food to treat a disease state. So when you think about health plans coming in and supplementing it, right, with a food as medicine prescription, it's very specific. It's the foods that person needs for their health outcomes and their diet, and it's with a trained professional. So if you're a diabetic, it could be paired with a registered dietitian who is prescribing those foods, and then it's built into the back end of the system. So those are the foods that person will be able to eat for their to help manage and treat their disease state. So I think it's not about replacement at all. SNAP's not enough to treat health outcomes.
Got it. And Sophie, from your perspective as a nutritionist, What do you see as the big opportunities then, given what Holly just said about it's not a supplemental benefit. I shouldn't use that term with the Medicare Advantage, but it's a different kind of, let's say, than what traditionally society is paid for. How are you leveraging that to improve nutrition in terms of individual patients and thinking about their disease state or in the case of maternity, their condition, which will be time limited, but moms who are breastfeeding need certain kinds of nutritional support. How are you taking advantage, or where are the opportunities to use this new attention to food as medicine to really support people who have nutritional needs that are different because of their health conditions?
Yeah, I mean, a couple different questions there. I think one of the challenges and kind of opportunities on the flip side is that some of the meal programs we're talking about within the food as medicine context can be limited in duration. And so, figuring out ways that a patient can have access to these services for as long as they need. If there's a patient with diabetes or a patient who's homebound and has, a heart condition, making sure that they can access meals that help them live their healthiest life for as long as they need them. Also figuring out how we can, address the root cause of their condition with appropriate education, not only providing produce, medically tailored meals, medically tailored groceries, but helping the patient learn how to effectively utilize the foods they're being provided, how to cook them, why they're eating them, what the end goal is. I think the other kind of opportunity is targeting younger populations so that we can start to, make healthier changes earlier in the life cycle. And you kind of brought up that point too, thinking about other health conditions where this is especially relevant, in the case of new mothers, during pregnancy or with a young baby at home, making sure that we're focusing on adequate nutrition, that people have enough to eat and that they're eating balanced meals. If we think about pregnancy or breastfeeding, does a woman have enough calories to consume so that she can support the child she's growing and then breastfeed them? So kind of a lot of different aspects here, but making sure that essentially people have what they need to prevent malnutrition. And that can be, overnutrition in the case of eating, excessive calories that are not beneficial for our body, and undernutrition in the more traditional sense.
Great. Thank you for that. A really helpful answer. I'm wondering, are there examples of successful food as medicine programs that we can look to as we think about the future? Holly, you mentioned that that's something the Milken Institute, that your program specifically works on quite a bit. What do you see as sort of the kinds of programs you'd like to see replicated and scaled across the country?
Well, I think when we look at scale, we're talking about, I want to just first start with the word program. So I'm going to go back to the very beginning. When we said food as medicine, I said I'd like food as medicine prescriptions, right? I think the concept of why, when we think of the term prescription, it's not a program, is it? You can go anywhere. Your doctor prescribes you a medicine. You go to whichever pharmacist you need to go to, and you're able to get the prescription. So this concept of when we see to scale, it needs to be really convenient to the individual, to the patient, to the person. So it's not just a program that lives in just one location, but it's readily accessible so that when they redeem this benefit, it could be at the store of choice, whether it's online, whether it's getting delivered to the house, whether it's a grocery store or a pharmacy or wherever it may be. And so I think that when we look at scale, it needs to be really easy for the consumer and the patient. Number one. And I think oftentimes we think about how do we scale produce prescriptions or how do we scale medically tailored meals, and we're thinking programmatically. And I think we need to redesign and rethink this frame of how do we make it so that people can easily take their medicine, if they're taking medicine, and take their food prescriptions or their food boxes, whatever you want to call it, and everyone wants to call it something different, right? So that they can have better adherence and better outcomes for their health. And so when we look at how we bring this to scale, I think there is no one answer. We have seen the standing up of community-based organizations doing phenomenal work to support those with the highest critical needs that may fall through the cracks of large-scale companies, right? And then there's many who just want to be able to have it really easy and deliver to their doorstep, go online and then just be all back-ended for them. And so when we look at scale, I'm seeing, just imagine, that this is readily available related to the Medicaid population, right? Also, we're seeing supplemental benefits through Medicare Advantage, and that is another way that we're seeing some nutrition supports moving through. But to be at scale, it means that we'll be able to see it across every state, right? And all population groups. And also to clarify, we're not saying that all the costs go onto the health plans, right? This is not all about the health plans. I'm talking about when we see this to scale, that it's not just for the most who are chronically ill, but it's about that patient care. So whether it's a doctor or a pharmacist or a registered dietitian who is, treating this person, they say, well, you need this for your health condition. And for some, it may be 6 months, which is what's allowed right now, or it may need to be longer. So I think we need to really think about this as a health treatment plan and not just a program.
So you're saying actually it's broader than just a health benefit administered by a specific plan. It needs to be more like a public utility where maybe this plan, when you have it, pays for it, maybe that plan, but there's sort of more generally agreed to approaches that everyone who meets certain qualifications would be able to access that program. Is that where we need to go? Is that right?
What I'm seeing is if you go to a doctor and they tell you that you have diabetes, they give you a treatment plan, right? And then they say, here's what you need to do. So when you think about that, food should be part of that treatment plan, right? And so if a doctor or a pharmacist or whomever is doing the prescription, right, that this can be, a covered benefit for specific conditions for a specific amount of time. And I always like to use the example of statins, right? So for statins, it's a longer term, an antibiotic is shorter term. So I think if you're coming out of the hospital and there's a very specific issue, that's a different answer than, like sort of that statin perspective.
Although I think some people would say you can't go to any pharmacy you want, and there's prior authorization, and it's the prescription model has challenges, right?
Yes, I was using that as a good example of going beyond the program. So yes, there's limitations on the prescriptions, and also I want to share that there's exciting news that we're releasing a report on June 3rd on the role of pharmacies in providing food as medicine care. So often we talk about food as medicine as the food, but we don't always talk about who are the care providers and who may be missing in that stakeholder group to provide that care. Of course, physicians, of course, registered dietitians, but I think sometimes we're not seeing who's right in our neighborhood of our pharmacist.
Interesting. Sophie, as a nutritionist, what's your take on this in terms of what are the best examples or ideas you have about how to ensure everyone has the best possible nutrition?
Well, I think what's kind of interesting, and Holly can maybe even speak more to this, is that there have been some different models experimented with in terms of how, the food prescriptions are playing out. And you brought up a really good point that most people don't think of filling their prescription as this like very straightforward, streamlined process as it is right now. So hospitals have experimented with, having their own food pharmacies available, and food pharmacies are popping up as a place where patients can get these prescriptions filled. So figuring out how to utilize the framework for food prescriptions, but in a system that works a bit more effectively for this type of service. And Holly, I don't know if you can kind of add on to that at all with your expertise on kind of what this is looking like in practice and how it's being made easier for patients.
So right now, I have to say it's not easy for the patients, right? Because it's different. So it's easy for a patient as long as they're on a specific program, right? They have their voucher or they have their card, but every health plan may be doing it differently. Every type of food as medicine program could be doing it differently. So if you're doing it for a medically tailored meal, it may look different than a produce prescription. So I think that to get to where we need to be, we really need to address interoperability, right? That ability, and we mapped in our recent report from last June, we did a report on market solutions for scaling food as medicine prescriptions. And we did a stakeholder mapping. And the stakeholder mapping showed 10 stakeholder roles in order to implement food as medicine. And they're not optional, like those are the pieces that need to happen every time. And then within those 10 roles, there's the data exchange needed. And when you look at this kind of graphic we created, you can see, to be honest, chaos of lines, meaning data needs to transfer in so many different places in order for this to scale. And so we need to start looking now at how do we have that data exchange? How does it connect from the health plan to the retailer? How does it connect from the health plan to the care provider? How does the actual customer know what's on their benefit plan and package and know how much is left? There's so many questions of how do we make sure that data is transparent to the people who need it to be able to make the decisions made, the policies, and the reimbursement.
So the track record, by the way, for health information exchange, just staying within healthcare, not fantastic. Ryan, this is something that Aeroflow deals with all the time, exchanging information with health plans, with either your customers, their members, with providers and their patients. Is this possible? Like, how do we get there? How can we share data more effectively and more efficiently?
It's definitely not an easy process. To Holly's point, it's there's a lot of stakeholders at play, and so you're trying to take disparate systems that have data structures that are different and trying to get those synthesized can be complicated. In our opinion, and kind of how we approach a lot of things that we do at Aeroflow Health is taking the first step and building that out and begin to iterate through as we learn going through that process.
So just figuring out how you bring that ecosystem of stakeholders together in a local community as a start, and then growing it and learning as you go. Is that right?
Absolutely. Yeah, I know it's from the time that I've been in healthcare for 15 years now, it's interoperability has been a buzzword that I think a lot of folks want to accomplish, but we haven't quite got there. I think CMS has tried diligently to figure it out with not a lot of success thus far.
Yeah, there are new rules and new regulations that are being implemented, but it is a huge task, and it's balanced by the risks that come with interoperability and connectivity, which have to do with privacy, and as we've recently learned, who can break in and ransom your entire system of payments. So there are opportunities that come with the interconnectedness, and I think we all agree that it's so important that it's worth taking those risks. But there are risks that we need to be careful about, and I think those risks have been used to prevent that interoperability in some cases in the past. And it's time for us to figure out how to moderate the risks. Life isn't risk-free, to minimize them and then move forward. And let's stay on the technology theme for just a second. How do we think about things like telehealth, mobile applications, using the device, using your phone as your way of keeping track of things? Like, there are all these different apps that we know about in healthcare. What is the opportunity for using technology to enhance the food as medicine journey? Holly, what are your thoughts?
So I think that we're already seeing quite a bit of movement in this space. We're seeing some more food as medicine companies coming in to help with interoperability. So it could be that company that is working with the health plans and whether it's a grocery store or a pharmacy or whatever the food as medicine facilitator may be, to be able to share that data and information. So we're starting to see some movement there. I think that we're seeing a movement in many of the different places for interoperability. It's just not all connected yet. And I think that's what we're looking at, is how do we start to connect those dots? We may have 3 of the 4 in this section and then 2 of the 4 there, and how do we connect those dots? And I think one of the things that we were learning in our most recent findings related to the role of pharmacies, right? Pharmacies understand HIPAA really well, so do physicians. And they can be able, and they're HIPAA compliant, but then how do you share that over to the front of the store, right? And then how does that front of store expenditures then report back out to the health plans on what that looks like. And those are where we're starting to see some of the gaps. Or with electronic health records, does the pharmacist actually have ability to see that information? And then when they transfer it over to registered dietitian, can they see it or not? And those are some of the gaps that we see, but we're also seeing a point in the right direction as well.
Great.
Hey,
Sophie,
Mike,
go ahead, Ryan. Yeah.
I was going to say, if I could add on to that, I think that's one of the roles that we, going back to why we got into this space as well, is that we realize that we can be an integrator of that, at least a part of that, to Holly's point, and integrate a lot of those touch points that we have the opportunity to have with the patients that we're servicing, and kind of synthesizing those data points within our own system with the patients that we're serving, and try to package that up for health plans and provide that data. I think as a prime example is that we're not connected with pharmacies as an example. And so they may have a set of data that would be beneficial for our clinical team as they navigate and are assisting patients, and vice versa, right? So we, in a lot of cases, if you take a diabetic patient, Aeroflow Diabetes is spending every month communicating with patients on their CGM device. And then folks like Sophie are working with them on the nutrition side as well. How can we take the data that we've learned through those conversations? And we've also built trust with those consumers of healthcare. How can we use that trust to gather additional information that would be beneficial for a pharmacy, for the health plan, for primary care specialist, et cetera?
It totally makes sense. So find the data where they are and then figure out how to connect the dots. Seems like a pretty good strategy. And are you finding that that's working out, Ryan? I mean, are you seeing that the people using the CGMs are willing to have you share the data back to their PCP or specialist, or the health plans expressing interest in that data?
We've not had resistance from the patient's perspective, and we're continuing to work with health plans to be able to provide that information.
Fantastic. Another use of the technology is to actually support behavior change. We all know how tough it is to stick to a diet. In fact, the concept of diet, I think, is no longer allowed to be said out loud. Is there a magic bullet app, or at least some apps that are helpful in terms of reminding us what a healthy diet is and how to eat in a more healthy way?
Well, I think it's less about the specific app and more about the access. The increase in popularity with telehealth now is providing greater access to education for patients without having to go to a specific physical location. So patients can see a dietitian without having to worry about the transportation, time off work, childcare. So we are now making it as easy as possible for patients or members to integrate new means of care into their current routines, without putting additional burden on them. When we think about, more specific services that technology can provide, recipe apps or cooking videos, lots of different, apps that do that now to teach people how to prepare new foods and how to implement healthy meals and snacks so they know how to effectively utilize some of the programs we're talking about under the food as medicine, umbrella today. And I think that's the key to being successful. It's not just the provision of these services, but really teaching patients how to integrate them into their lives in a way that works for them. I think the other interesting thing that technology is enabling is timely access to education and to dietitians. So in the past, a patient might have to wait weeks or months to see a dietitian, and now we have these large networks of providers. So there's no extended waiting time to get in. Patients can have, real-time messaging with providers to ask questions when they're in the supermarket or eating a meal to figure out, the burning questions they have. And then, like you mentioned, food logging and journaling apps so that they can continue to stay on their plans and programs and committed to the goals they have over time, and to share information with their dietitians that way as well.
So let me ask a question related to that. So if you have someone who has diabetes, for example, So they have a continuous glucose monitor, so they're watching their blood sugar very carefully. Maybe they also have an insulin pump if they're type 1, or someone has advanced type 2 diabetes. How do the specific nutritional needs impact that patient? And how is that different than what a nursing mother might need, or someone who has sleep apnea and suffers from obesity? Is it that you need a separate app for each of those? Is it the app doesn't matter? It's really just making sure that they have good access to nutritional support or advice. How do you put together sort of the food as medicine with specific disease states?
Yeah, I think the key word that you mentioned is support. Ensuring that all patients have the right type of support so that they can maintain changes over time. Like I mentioned earlier, with any of these conditions, we want to address adequacy of nutrition. So making sure that any of these patients know how to eat a balanced diet. And there's a lot of, similar nutrition concepts we're looking at across these different life stages or disease states. So, we're looking at diets that are high in fiber, high in whole grains, lots of produce, fruits and vegetables, less saturated fat, less animal meat or less red meat, and trying to reduce refined grains and all the sugary foods and fried foods. So regardless of condition, those are going to be beneficial, nutritional goals to work towards. And then with sleep apnea, focusing on weight loss. If somebody's overweight, focusing on physical activity. We talked a little bit about, pregnancy and nursing earlier. And then if a patient has diabetes, trying to decrease fat intake, especially saturated fat, and get that down, continuing to focus on weight loss. So, for any patient, their needs are going to be specific to them. But I think the important piece is that they have ongoing support from a dietitian who's really a partner in their journey, and that they're learning, how to adopt a diet that is, on paper, nutritionally adequate, but less about perfection and more about what's going to move them in the right direction.
And, Holly mentioned earlier the role of pharmacists, the role of physicians, lots of potential clinical involvement. You mentioned influencers, right? Sophie, about there are people on social media who can help you cook and tell you it's amazing how food fads like move so quickly now, at least in my family, because my kids will see something and they go, oh, we got to try this. And we usually do. But what's changed in terms of access to nutritionists specifically? Have health plans change their benefit designs? It used to be like if you're diagnosed with diabetes, you get 1, maybe 2 visits with a nutritionist, and then you need everything you need to know. Is that evolving? Is that changing? You said there are now networks of nutritionists, but are health plans willing to pay for ongoing access?
Do you want me to answer that? Okay. Yeah, absolutely. I think with commercial plans, we're definitely seeing increased access to medical nutrition therapy services, which is very exciting. Medicare is a bit behind. For Medicare Part B, right now they're covering access to medical nutrition therapy if a patient has diabetes, chronic kidney disease, or recently had a kidney transplant. But on the horizon, which is kind of exciting, is that there are bills in Congress and the Senate called the Medical Nutrition Therapy Act, which is trying to increase access to the eligible conditions that patients could see a dietitian for. And also increase the list of providers who can refer patients to a dietitian for medical nutrition therapy. So we're definitely moving in the right direction there, but there's still a ways to go for government insurance.
When you say medical nutrition therapy, what does that mean?
Yeah, so that's it's a formalized process of working with a dietitian where there's a nutrition diagnosis the dietitian's assigning, and they are working on nutritional interventions for a specific disease state. So, if a patient has hypertension, type 2 diabetes, hyperlipidemia, they would be working with a dietitian on how to use food to treat those conditions, as opposed to somebody who just wants to get healthier to live their best life, which I support as well, but not officially M&T.
Got it. And Ryan, you mentioned that Aeroflow has engaged Sophie and is building out programs for medical nutrition therapy. Are you seeing success in that? Are people taking you up on that in terms of, are the folks who have continuous glucose monitors or new moms who are breastfeeding, are they enrolling in those programs? Are they starting to use them?
Yes, we are starting to see definitely on our mom and baby side, but early good take rate on the airflow diabetes side. I think the important part, and I'm not sure if Sophie or Holly mentioned this, but it's about meeting the patient where they want to be met, how they want to be met, and being able um, to capture information and data and help them make an informed decision in that moment. And I think there's a lot of value in that. As a somewhat of an anecdotal example, I guess myself, I trialed a CGM device for a period of time, and it was interesting the data that was provided versus the food that I took in, and some of the things that I thought might cause my glucose levels to increase actually didn't, and some of the things that did increase those levels, I was kind of surprised. And so I think someone who is navigating that and having to live with that disease state day in and day out, it's a huge benefit being able to tap into a telehealth nutrition session with someone like Sophie to be able to help navigate and understand what that looks like for them and their body, and ultimately creating behaviors. And that seems to be kind of a theme that has come up on this webinar, is that we want to be able to create the right behaviors for those folks that so they're not chasing the next fad diet or thing to eat, as you had mentioned.
Thank you. Holly, this one's for you. So you mentioned 10 stakeholders, and it was kind enough to put in the chat the link to that. So if people want to see what that diagram looks like, you're welcome to take a look at it. And if you have questions for the panel, I see one there we'll get to in just a second. If there are others, feel free to pop those into the chat now. But how do you get those stakeholders together? How do you bring together people who may not think of themselves as an obvious source of nutrition? Like some pharmacies, for example, may see themselves as the sources of nutrition. Others just may not have that as front of mind. What are the strategies for bringing together a food is medicine coalition and a movement at the local level? All food is local, all health is local, but also regional and also national.
So let's just start with the fact that there is really strong coalitions that already exist. We don't need to recreate the wheel. And so I think about the Food is Medicine Coalition, and it is a phenomenal coalition that really looks at supporting community-based organizations, right? And so that is like, if you're looking from the CBO perspective, there's that coalition. Then you're also looking at different academic institutions, right, are really bringing together different stakeholder groups. We at the Milken Institute, we're really looking at, I lead the Food is Medicine Task Force, and that task force includes health insurance companies, plans, retailers, and then other food is medicine companies, but it's very much a cross-sectoral private sector task force. And so that one example, when I mentioned the Food is Medicine Coalition, much more CBO focused, we're much more private sector, understanding we're all working together. And so when you're thinking about looking at how do you build stakeholder groups, I think when we first start is, it's a line I think we never like to say, but we say it anyway, it's like you follow the money, right? And so when you look at, as we see policies change, then it's going to open the opportunity for us to be able to partner. So for example, pharmacists have great opportunity to be a part of the Food is Medicine to provide care, but if they don't get covered for their services, then they can't provide it, right? They can't do things for free. And so, and the same thing that we're seeing in the food is medicine space, that we can't provide food is medicine prescriptions if some of the food is not covered, right? And I think for the health plans, what we're seeing, and I'm kind of linking into this question that was asked on the Medicaid 1115 waivers. One of the things that we're seeing with the health plans right now is not knowing when to mobilize and use the 1115 waivers or not. And that we're seeing that even when we get these waivers put in place, if people don't understand or know what they are or the benefits or the value, then they don't get utilized. And so that's just a quick sort of overview. And Mike, when you get to the other question, I can go into more details on 1115 waivers.
Let's jump into that now. So what is an 1115 waiver and how does it affect food as medicine?
Great. It has a big influence. So the Medicaid 1115 waiver is a demonstration. So it's not a benefit for all Medicaid. It is only for, it's a waiver. And so the Medicaid 1115 waiver can include many benefits, not just nutrition and not just food. But I'm only going to talk about the nutrition related benefits. So with the Medicaid 1115 waivers, depending on the state, and every state is doing it differently. It's like pick your own state and pick your own experience. That the nutrition supports, and it's really called nutrition supports in the waiver, can include medically tailored meals, can include medically tailored groceries, and can include produce prescriptions. Doesn't mean they do. Some do, some don't, depends on the state. And that it is a covered benefit. But with the 1115 waiver, it's very interesting because when you think about it from the plan's perspective, right, and the insurance perspective, it's not new money. It's the ability to reallocate existing money to cover nutrition supports. So from the health plan perspective, it's not new money, it's just that they are allowed to do this. Now, if you ask a grocery store, you ask a food as medicine company, they'll say, oh, this is new money to me, right? And it might be that they're getting a reimbursement to be able to cover and food as medicine prescriptions. So I think that right now with the Medicaid 1115 waivers, we have seen a pretty significant change. Right now we have 8 approved states and 5 pending. So we're talking, and I think a few years ago, we were talking about like 2 states. So it'll be 12 probably by the end of the year or more of the 1115 waivers, and it's a demonstration. So the intention here is that with each of these states and these Medicaid 1115 waivers, we're building large scale evidence and data, which is what we're needing. We need to move out of grants and pilots. And so with these, and we need to see a few more states or more states come on, so we have large scale data to see, does this become a covered benefit? And if it does, for what condition, what length? Is it age related or not? Is it disease related? And that is what's really excited as we're seeing this movement of 1115 waivers. Now, the downside to it is because every state is doing it differently, so like in California, they have, I'm making up the number, but let's just say like 20, 30, 40 different supports covering the waiver, whereas another state might only have two supports, one on nutrition and one on transportation. And so the scale and type of supports is really varying.
Got it. So the usual American way, you let people choose their own adventure, and the result is hard to compare data with very different answers depending on the state and the design of that program.
The data will be consistent, to be clear. So the data that CMS is getting will be consistent for nutrition supports. It's just that each state may be doing different supports.
Right. So the interventions will be different, but the measurements will be consistent. Great. So unfortunately, our time has sped by, I think largely because of the interesting aspects of this conversation and how great our panelists have been in responding to my questions. So it's time to wrap up. Let me remind everyone in closing that a link to the on-demand webinar will be shared very soon and some resources that go with that. Please feel free to subscribe to our newsletter at Aeroflow Health. We'd love to have your feedback on what went well today, what didn't go as well, and what we should do in the future in terms of other topics. So please let us know so we can get you the information that you'd like and find valuable. And of course, follow us. Follow us on Aeroflow Health on social media. We're on all the major platforms. Thanks to all of you, to each of you, Sophie and Holly and Ryan, great discussion. I look forward to continuing to have these discussions because Food is Medicine isn't ending next week. And hopefully we'll continue to see progress in adding this really valuable set of benefits and supports for people's health. So thank you all for your participation today and really appreciate it. And to those who are watching, thank you for joining us. For those who are watching us on recordings, Really appreciate the time you spent watching this webinar and look forward to talking to you again soon. Thanks, everybody.
Great. Thanks for having us.